Hello, let's talk UTIs. The most common cause of a UTI is E. coli, and that's a gram-negative rod. It's a lactose fermenter. You can find it on McConkey's agar or eosinmethylene blue, but it'll grow on most anything. E. coli, there are a lot of different strains, but the one that we care about in urinary tract infections is called UPEC, uropathogenic E. coli, and it gets to typically the female urethra by means of just kind of migration from the anus over external skin into the vagina, into the urethra. And so then E. coli UPEC variant typically has lots of fimbriae that mediate attachment to this mucosal surface and allow it to ascend up the urethra to the bladder and then potentially even farther up the ureters into the kidneys to cause a cystitis and maybe a pyelonephritis. So E. coli is your number one go-to. Staphylococcus saprophyticus is the second most common bug isolated in UTIs. Remember that that's novibacin positive. And it's coagulase negative to differentiate it from Staph aureus. We've also got Proteus mirabilis, which is a gram-negative rod that has urease and likes to contribute to the formation of struvite staghorn stones composed of magnesium ammonium phosphate. Then we have Klebsiella pneumonia, which Klebsiella, what is more commonly known for lung abscesses in alcoholics and aspiration pneumonia. That's urease positive. That's a lactose fermenter as well, gram-negative rod, again, encapsulated. And then Enterococcus fecalis, that's a gram-positive coccus. And the sketchy micro for that, I just remember the protesters holding a sign that says, "Do you love tree?" I think that's what it says, because it can cause a UTI, it can cause a carditis, that's why it's got a heart in the middle, and then it can cause a biliary tree infection too. So you've got enterococcus all throughout your gut, and your biliary tract's connected to your gut. And then, as we just said, migration of gut bacteria from the anus to the urethra is a much shorter distance in females than males. So let's break apart this SDL. Whenever you're diagnosing a UTI, you're thinking lower versus upper. And when it's upper, it's in the kidneys. And if it's lower, it's confined to the urethra and the bladder. And so this is a really easy differential diagnosis. If it's an upper UTI, the patient will have flank pain, or they'll potentially have fever and nausea, vomiting. It'll be a way more severe infection. And then finally, the patient might show white blood cell casts in the urine. And so you know what a cast is, and you should understand that there is no way that you would ever see any sort of cast unless the kidneys are involved somehow. A red blood cell or a white blood cell or a muddy brown cast, that's in tubular necrosis. Those are all pathologic casts. And so something like a hyaline cast, you could see that in a lower UTI, but a pathologic white or red blood cell cast, that indicates kidney infection. So a UTI can be uncomplicated or complicated, and there's a lot of different things that can give you a complicated UTI. Some big ones are male gender or pediatric UTI or pregnant woman or patient in the hospital. All those examples are going to give you a complicated UTI, and we've got a section called Complicated Pyelonephritis, which is treated a little different than uncomplicated because of the higher pseudomonal risk. Bottom of page 2, the difference between a relapse and a reinfection of UTI. A relapse is the same exact microorganism. You take the second swab, first infection resolves, you treat it, patient has another one, you swab and plate, and it's the exact same thing. That's a relapse. Now, a reinfection, you swab and plate, and it's a different bacteria. So the population, the demographics of UTIs, women get UTIs at extremely higher rates than men because they tend to have shorter urethras, and so it's easier to get a cystitis, a bladder infection, when your urethra is like that compared to like that, you know. And so women also have urethras that are just closer to the anus than men do, and so it's easier for GI bacteria to make their way up to the tip of the urethra. A section on bacteria here. What you really want to know is that there are 3 different antigens in UPEC, which is that uropathogenic E. coli, and these 3 different antigens predispose to 3 different types of diseases. So if the UPEC that you plate and grow from a patient's UTI is shown to have type P fimbriae. What that means is that the patient's probably experiencing an acute pyelonephritis. And then on the flip side of that, if you make the clinical diagnosis of acute pyelonephritis and then you plate E. coli, you can just about assume that it's got type P fimbriae. Type 1 fimbriae, correlation there is with cystitis, a bladder infection, and then type DR, maybe that's type Dr. fimbriae, a chronic pyelonephritis, not acute, a chronic pyelonephritis. If your patient's got these recurrent episodes of kidney infection, then you're thinking, okay, it's this E. coli UPEC variant with a DR fimbriae. That's about all you need to know from that page. How does the bacteria get into the bladder, the ureters, the kidneys? Well, typically, again, they enter through the urethral meatus and they just climb straight up because these bacteria that cause UTIs have one thing in common. They have fimbriae and pili that mediate their attachment to the slippery endothelium. So imagine trying to walk on ice. It's not too easy, is it? But if you put on some ice skates, you could get out there and Sidney Crosby it, you know, Wayne Gretzky it. So bacteria that don't have very good fimbriae, they're just out there on ice in their socks, you know, like they're hopeless. But these E. coli and this Proteus mirabilis and this Staph saprophyticus, they all got really good pili and fimbriae. It's like they have ice skates on. So your body has a pretty good defense mechanism against UTI. In this TAM horsefall protein, it likes to bind fimbriae and prevent fimbriae from binding to your urothelium. And so that's one thing. But then also the mechanical flow of urine out the bladder down the urethra also helps to push out pathogenic bacteria from that urothelial surface. And rarely, very rarely, you can get a pyelonephritis from hematogenous spread of septic bacteria, bacteremia, such as Staph aureus in the setting of endocarditis, or maybe you have a candidal endocarditis in an immunocompromised patient, and then TB does like to go bacteremic as well. But those are extreme, drastic examples, and you would make the hematogenous connection like that if you saw that on a test. So first, we talk about asymptomatic bacteriuria. What do you think this is about? Well, you've got bacteria in your urine and it doesn't cause symptoms. That's about all you need to know. So we define it a little differently. For men, it's one sample that plates an organism is positive for asymptomatic bacteria. But for women, you've got to get 2 samples in a row that are positive for the same organism to qualify it as asymptomatic bacteria. And then in patients with a catheter in, the threshold for making this diagnosis is a lot less, 100 colony-forming units per milliliter as opposed to 10,000. And that's because catheterized specimens are just less likely to be contaminated. And so positive cultures do indicate true bladder bacteriuria at a much lower concentration, again, in that catheterized population. So what's the relevance of asymptomatic bacteria in the urine? Why do we care if it's asymptomatic? Well, it could really complicate things in pregnancy, and it could also complicate things if patient comes in with something like a pelvic fracture or they've just been in a crush trauma and they need some sort of urological intervention and reconstruction to hold them together down there. If the patient's got asymptomatic bacteriuria, you want to completely sterilize them before you go about correcting the urological problem. Cystitis is a bladder infection. It's most common in premenopausal women. And the incidence of symptomatic cystitis, just straight up bladder infection, in this population is roughly half a UTI per person year. So that's astounding. You can get it in postmenopausal women too. You can get it in men, of course, but much, much less lower. That's like 5 UTIs per 10,000 individuals, as opposed to, you know, one UTI per 2 individuals. Geez. So if we've got a bladder infection and it's E. coli, that E. coli has type 1 fimbriae. There you go. Test question right there. Number 1 risk factor, recent sexual intercourse. I feel like we're getting a risk factor question here because of this rather large, this girthy table at the top of page 6 here. What you need to recognize is recent sexual intercourse is number 1. But if that's not on there, then some independent risk factors are diabetes and pregnancy. and in particular diabetes, because bacteria just love glucose. And so if you have a high blood glucose, well, then every tissue in your body is going to have a high glucose correspondingly. And so your urothelium's got a high blood glucose, and bacteria just eat on that. They feast on it, and they just go straight up into the bladder. So recent sex, pregnancy, diabetes. How does a bladder infection present clinically? Well, dysuria, problems with frequency or urgency or pain during urination, or possibly hematuria, all those make sense. I don't got to explain any of those. But the differential is pyelonephritis. And so what you will not see in a cystitis is flank pain. No way. No way, you know, it's the bladder that's hurt. It's going to be suprapubic pain. You're not going to see white blood cell casts in the urine in case the patient's got the very, very rare cystitis superimposed on pyelonephritis, you know? And then you're not going to see any fever because it's the bladder. It's so far down there, and it's not got the same blood supply as the kidneys do. Those receive 25% of your blood constantly, you know? And so you're not going to really see any sort of fever or like systemic reaction to cytokines. You're not in real danger of urosepsis in the setting of a cystitis. We want to do some urine tests whenever we're suspecting this. We want to look and see the white blood cell count, cellularity of the urine, and 6 to 10 or more neutrophils per high power field of unspun, voided, midstream urine is what's going to check that diagnosis in terms of pyuria. And unspun urine, that refers to urine that hasn't been centrifuged in a tube. And so there are various reasons why we would want to do that or not do that. We would want to centrifuge it if we were really looking for casts, because we would want to sediment them all in the bottom. But if you're suspecting, again, urethritis or cystitis, then maybe you don't want to centrifuge it, because then you're reading some signal from the kidneys too at the cellular level. How do we collect the urine sample? Well, the gold standard is suprapubic aspiration, but can you really imagine sticking a needle in someone like right there, you know, and just like, no, me neither. So we just have them pee in a cup. Much better. We don't care about specificity, sensitivity. Look, we'll get as many samples as we need to try and confirm this. So you toss the first sample, you send the second midstream sample for your analysis, and that's the process, that's the program. Dipsticks, we like to use urine dipsticks. They tell us a ton of information, including things like pH, glucose, albumin, but really in the setting of cystitis, the two readouts we're most interested in are leukocyte esterase and nitrite. And esterase is just an enzyme in white blood cells, and the higher it is in the urine, the more white blood cell activity there is, indicating infection. And then nitrite is a byproduct of bacterial activity, and so the more bacteria there is in the bladder or the lower urinary tract, the more nitrite that you're going to see positive on a dipstick. Finally, randomly, TAM horsefall is that cast glycoprotein, and it's made in the thick ascending loop, and it's also called uromodulin. If you ever see the word uromodulin, what they're referring to is TAM horsefall protein. So now we talk about pyelonephritis, which is a kidney infection. It's typically a complication of a urethral or a bladder infection, because to get to the kidneys through the ascending route, you have to pass through the urethra, then the bladder, then the ureters, up into the pelvis, then you get the calyces, and then finally, bang, you're hitting the tubules hard. So pyelonephritis, kidney infection, very good morbidity, not good, but high morbidity in this condition. Women get it more, same as every UTI, because they have shorter urethras. But because of the mechanics of vesicoureteral reflux, pyelonephritis is actually also common in the pediatric population. Very prevalent in the postnatal period, because vesicoureteral reflux means that fluid from the bladder is leaking up the ureters back into the kidneys. And if you have a congenital anomaly with the vesicoureteral junction where the ureters empty into the bladder, you're not going to see that at age 16. You know, it's not going to take that long to present. You're going to know it like the first or second or third time that bladder ever fills up. It's going to spill back, and it's going to really irritate the kidneys. And yeah, it can lead to an infection that way. So E. coli is the most common cause. It's got P. fimbriae in acute pyelonephritis. Again, keep that separate from chronic pyelonephritis that's got DR fimbriae. And it complicates a handful of pregnancies, and that's a real bad situation. We're going to be treating this with fluoroquinolones for that good gram-negative coverage and the pseudomonal coverage as well. So vesicoureteral reflux is, as we said, urine's in the bladder, spills upwards proximally into the ureters during contractions of the detrusor muscle and micturition. And so it's typically, again, due to congenital absence of some degree of musculature or connective tissue in this region of the bladder that should be pretty heavily sealed off, should be pretty watertight. But in cases of reflux, it's not, and it doesn't close properly. So you're lacking maybe connective tissue, or you're lacking a layer of sphincteral muscle. Maybe part of the detrusor did not fill in properly. And so that's why you've got this patent vesicoureteral junction that allows spillage of urine back up. It tends to be congenital. It could also be acquired if you keep getting bladder infections and the inflammation surrounding the vesicoureteral junction gets so bad to where it just completely fibroses the flap you see here on the left-hand side. It can fibrose that flap and hold it open. And so then you'd see urine backflow that way too. And then finally, in cases of maybe neurogenic bladder or BPH, patients having a hard time voiding, that bladder just gets abnormally large. And so the extreme and abnormal pathologic pressure of urine within that bladder could just pop that valve open mechanically by force. So we measure for vesicoureteral reflux by taking a voiding cysturethogram. And we had a quiz question on this. Remember that this means we're pushing dye up the tip of the urethra all the way up into the bladder. We're not giving them a dye to drink and waiting for it to make its way through the kidneys. No, no, no. We don't want any dye passing through the ureters, because that would be a positive test, right? So we have to put it in distally from the other way. Radiologic appearances of this reflux are graded on a numeric scale. This is, to me, the dumbest thing to ask a question about, but it's also really easy to write a test question about it. So you might see a pathology clin med question about, oh, here's a voiding cysturethogram. What grade is it? And so you go and you look, and like, for example, on this one here, you'd say, okay, well, it's going all the way up the ureter. It's even going up to the renal pelvis. It's even going way back up to the calyx. And so that's a grade 4 or a grade 5, you know. I would say that's a grade 4 because you can still make out the impressions of the papilla down where the renal pyramids are meeting the minor calyces. So not only can you have vesicoureteral reflux, once the fluid moves up to the renal pelvis, you're out of the bladder, you're out of the ureter, you're into the kidneys. And so even though it's the same exact process of reflux, you just call it intrarenal reflux. And so vesicoureteral reflux generates intrarenal reflux. And the reflux tends to go to the poles of the kidneys because the poles of the kidneys have these compound papillae that have a divot in them. And so fluid wants to go into that divot because it's spatially permissive to mass. Fluid is going to hit this simple papilla and crest down the sides of it. But then fluid is going to hit this compound papilla and collect inside that divot and push that divot farther and farther in. Whereas you're going to have a hard time pushing this papilla in. You'll just push down over here, push down over here. Hematogenous seeding, again, endocarditis, septicemia, patients got some bad disease that you're going to get told in the questions. So what do you see when you look at pyelonephritis grossly? Wedge-shaped areas of pus. You might see large abscesses in the kidneys. Microscopically, you're also going to see large abscesses. And so because there's a lot of pus, you understand that what is pus? It's just a bunch of dead neutrophils, essentially, plus bacteria. So you're going to see a ton of neutrophils on histology, and it's not going to surprise you. And you're going to see, other than the immune infiltrate, you're going to see a lot of sections of relatively otherwise normal DCTs, PCTs, glomeruli, versus chronic pyelonephritis, in which it's just wiped out, you know, lots of fibrosis in a chronic pyelonephritis. So you want a differential pyelonephritis from a bladder infection. And again, are you going to see flank pain in a pure cystitis? No way, never. Are you going to see fever in a cystitis? No, not unless it progresses up to the kidneys, really. Are you going to see nausea and vomiting in a bladder infection? No, your bladder's below your gut. No way. But your kidneys are right behind it, so that should make sense for you. And white blood cell casts. You will not see casts in a bladder infection. You will see it in a kidney infection. We're going to treat it with fluoroquinolones. That's our floxacins, remember? And those are our DNA topoisomerase 2 and 4 inhibitors. And they got a good gram-negative spectrum, and they cover Pseudomonas as well. CT is imaging of choice because it catches the abscesses. Those are just pockets of fluid. Complicated pyelonephritis. We said it's going to be a complicated infection if the patient's male, pediatric, pregnant, or hospitalized. 4 big categories there. So what this means is that we need a really good drug for this, and we need to be prepared to maybe throw another drug at it in case it doesn't work, because there's an increased rate of therapy failures for complicated pyelonephritis, and also increased risk of mortality, largely through urosepsis, which can produce a septic arthritis, an osteomyelitis, or an endocarditis. So Pseudomonas loves to get that osteomyelitis, especially in what patient population? Diabetics. Pseudomonas gives diabetics osteomyelitis. And septic arthritis, similar dig there. And you see abscesses. Other than the potential risk for sepsis, the presentation's largely the same. Serratia is another pathogen that you see in complicated, more often than uncomplicated, but E. coli is still the predominant culprit. Diabetes is bad. It predisposes these patients to UTIs because bacteria like glucose, but then it also predisposes to Pseudomonas osteomyelitis, and that's complicated. So renal and perinephric abscess, the point of this section is to tell you that you get renal abscesses, which are in the functional tissue inside the kidney in settings of pyelonephritis. But you get perinephric abscesses, which peri, that means around. So around the kidney, in the capsule of the kidney, you will get an abscess there, and you'll see it in the setting of an extrarenal infection. And so this is when your really good radiologist is going to point out to you, hey, this is really peripheral. I think that this is probably a capsular abscess and not a parenchymal abscess inside the kidney. And you're going to say, ooh, okay, so maybe not pyelonephritis. Maybe we got a lower GI infection. Maybe we've got a diverticulitis. Patients have a fever because they have an infection. Of course they have a fever. Patients are going to have potentially vague lumbo-abdominal pain, not necessarily going to be localized to the flank, especially if it's perinephric. And then as it gets bigger and larger and compresses different organs, you will see not just flank pain, but then it'll also maybe start moving up or start going to the front because it'll get referred through different sympathetics that it'll push against. You're going to see a pyuria, of course, duh. And imaging of choice, CT scan. It's an abscess. You can see abscesses really well on CT scan. Xanthogranulomatous Pyelonephritis. What's that mean? Xantho, where have we seen that before? Xanthelasmas, xanthomas. What sort of disease is that involved in? Hyperlipidemias, hereditary hyperlipidemias. You see these plaques around the eyes, right? And then on the extensor surfaces, these yellow bumps. And what's in the bumps? Cholesterol. And what sort of cells are in those bumps? Lipid-laden macrophages, also known as foam cells. Same exact cells that you see in this. Granulomatous, what's that mean? It means you got giant cells. Somehow, some way, you've got multinucleated giant cells. Pyelonephritis, what's that? Infection of the functional tissue of the kidneys. So, you know everything about this now. What you need to know is that Proteus really likes to cause this. So do your read up on Proteus. Remember, it's got swarming motility when you plate it. It's a gram-negative rod. It's got urease, and the fact that it has urease is what helps it to produce these magnesium ammonium phosphate struvite stones that tend to look like staghorn. They're called staghorn calculi because they kind of look like antlers or like a staghorn beetle. You know how it's got that big kind of mandibular process to it. It's got a characteristic histology pattern. It's got a characteristic patient, middle-aged women with a history of recurrent UTIs, and it's even got a characteristic gross look with yellow to orange nodules and a lot of fat in the kidney. So you are going to have no problem at all diagnosing this. Same thing with emphysematous pyelonephritis. You get a necrotizing infection. It's going to produce some gas just due to simple metabolism and fermentation of short-chain fatty acids and sugars. And so when bacteria ferment, that means they're doing anaerobic metabolism and they're producing carbon dioxide, but also hydrogen gas. We've seen that in the colon and especially in the kidney, nitrogen gas, because there's a ton of urea there. And all these bacteria can metabolize urea. The bacteria that can't, you know, they're not going to infect the kidney. They don't want any part of nitrogen. Nitrogen's toxic to them. So E. coli, Klebsiella, and Clostridium. Clostridium perfringens. What's the superficial SSTI you get with Clostridium? Gas gangrene. Crepitus. You palpate it and it crackles like firewood, remember, or like crackles in the lungs. That's crepitus. That's Clostridium perfringens. That can give you a gangrene too. It's gas gangrene. And gangrene is just infection on top of tissue necrosis. So diabetes predisposes you to this as well. Notice a pattern here. Bacteria love glucose. Period. End of discussion. So how's it present? Exact same as pyelonephritis. You got flank pain, you got fever, you got a high white count, you're going to have a pyuria. The pathognomonic finding is gas in the renal parenchyma, and non-contrast CT is the diagnostic method of choice. Let's take a look at some photos here quickly. So I'll start with emphysematous pyelonephritis and work my way backwards. Here's a CT axial showing you so much air in this kidney, yo. And you know it's air and not fluid because it's the exact same color as the background. So that right kidney there is filled with a lot of air. And there's your normal left kidney right there. And we're looking at the lower lobe of the liver, or the right lobe of the liver, sorry, on the left there. And then we kind of got a aorta, an IVC right there, and maybe a little bit of pancreas right there too. Here we are looking at air in the kidney. That big black space right there, same exact color as the background, same exact look as the air that's in the transverse colon right there. And then here's a normal kidney. It's got fluid in it, doesn't have any air though. Here's your Xanthogranulomatous Pyelonephritis. Here's your foamy histiocytes. Histiocyte means macrophage. Hey, it's cool. You've seen that word before. You keep a level head. You know what a histiocyte is. And you can see some giant cells too. Here's what it looks like grossly. Many territories of fat deposition and a grossly yellow color to the kidney, which should otherwise be kind of beef colored, you know. And here's a particularly fatty kidney on the right side here. You should not be seeing fat right here in the cortex of the kidney. We're looking at it's bisected and kind of the pinkish tan tissue I'm trying to outline here. That would be like a calyx draining into a pelvis, and the pelvis is going to be kind of this cup space in the middle. And so then, yeah, notice all the yellow accumulation inside that pelvis there. It's the pelvis, not the cortex, my bad, but it's inside the pelvis, and it's inside the pelvis on this side too here. Just a lot of fat. And on CT, this is going to be the shrunken kidney, the bad-looking kidney, the homogeneously dense kidney. And the kidney on the other side here, that's our normal kidney. Yeah. So a chronic pyelonephritis, let's look at acute first. Here we're looking at, these should be, let's orient ourselves. You've got a glomerulus here, and you've got a slice of the kidney, so you know that the histology of the kidney, if it's not a glomerulus, then it's a PCT or a DCT or a loop, basically, or a collecting duct. And so you've got a glomerulus there, and all the rest of this image is the renal tubules. And so what you're seeing is neutrophils inside the renal tubules. Could be PCT, DCT. It's blown up so much to where you can't really tell what individual parts of the nephron are infected. All you can tell is that there's a lot of neutrophils here, and even a patch of red blood cells in the very center of this image that are clearly ruby red. And then down here on the lower right, you've got a normal proximal convoluted tubule down there that has not been infected. And you've got another normal PCT right there, another normal one right there, but they probably will be infected pretty soon. So that's the neutrophil infiltration. The fact that you do see all these normal tubules means it's acute and not chronic. Here's a chronic pyelonephritis, and here's your pyelonephritic scarring that the SDL refers to. You get a lumpy, bumpy appearance on the outside of the kidney. Here it is on CT, one kidney smaller than the other. Here it is on an axial section, one kidney smaller than the other. Both are lumpy, bumpy. Here's the histology of a chronic pyelonephritis. What you really need to know about chronic is that you get these eosinophilic casts inside the renal tubules because I don't know why. I'm going to venture to say it's because you got a proteinuria due to kidney damage, but I'm not totally sure. But there at the top of the section, those are your eosinophilic proteinaceous casts. And elsewhere in this section, what else are we looking at? Well, we see some, if that's a glomerulus, that's periglomerular fibrosis. But if that's a capillary, then that's, or a large blood vessel, then that's just fibrosis around the lumen of a large blood vessel. And both of those are very common in chronic pyelonephritis, those sorts of lesions. And then notice there's so much blank space within this kidney with just no cells at all. It's been wiped out and scarred up. And so then here is a final handy little graphic to show you this protein accumulation or thyroidization of tubules. Also, periglomerular fibrosis is a characteristic finding again, and you're going to see macrophages and lymphocytes on histology. So that's all the pictures we got. Let's get back to the SDL. Renal papillary necrosis. What is the renal papilla? The papilla is the anatomical name for the region of the medullary kidney at which the pyramids empty into minor calyces. And so, order of operations here: glomerulus, Bowman's capsule, proximal, loop, distal, collecting duct. Down collecting ducts merge and fuse and form papilla. There we go. At the tip of the renal pyramid, you've got a papilla with so many thousands of collecting ducts fusing and throwing fluid into it. And then that papilla transitions into a calyx. So if we've got papillary necrosis, that's pretty bad. And that's going to wipe out a giant area of your functional kidney if it can't drain properly. Because again, thousands of nephrons empty into one papilla. So why do papilla get hurt? Because of ischemia. What's going to give you ischemia? Low cardiac output is absolutely going to give you renal ischemia. Something that would plummet your GFR is probably going to give you renal ischemia, like a combination of an ACE inhibitor and an NSAID. Something like a pyelonephritis could injure the tissue in there and give you a renal ischemia. So you get ischemia, and the papilla is the first part of the kidney, that one of the first parts that will die. It'll preferentially die the same exact way that the subendocardial layer of the heart dies, the same exact way that zone 3 of the liver is the first to die, because it's the farthest away from oxygenated blood. So that's why the papilla dies first, and it's particularly supplied by the vasa recta, which looks exactly like vasa recta in the GI tract. So there's nothing about this pathology that you don't already know. Again, how do you get ischemia? We said low cardiac output's a great culprit. Also a thrombus, an embolus, a thromboembolus, maybe a vasculitis. Systemic vasculitis can manifest in this way. And so if you get a vasculitis and kidneys are hypoxic, the papilla is going to be the first to go. And then maybe some nephrotoxic drugs as well can damage the tubules. and cause hypoxia that way. We're thinking aminoglycosides there, but there are a ton of them. Coagulative necrosis is what you see here. Of course it's coagulative necrosis. How could it be? It's not going to be enzymatic fat necrosis. It's not going to be fibrinoid necrosis. There's no neutrophils. It's a hypoxic process, so it's not going to be liquefactive necrosis, so of course it's coagulative necrosis. That is our normal baseline necrosis, and that means cells keep their relative architecture when they die. Big complication here is that as the tubule dies, tubule epithelial cells can slough off and clump together and obstruct distal downstream papilla or parts of the ureter, and that's really bad. That's going to give you a hydronephrosis. That's about all we got about that. Section on pyelonephrosis and urosepsis. Just understand you can get sepsis from the urinary tract. Polyomavirus associated nephropathy, that's going to be BK virus following a kidney transplant. It's a circular double-stranded DNA virus. It's a naked virus. That's all I got on it. Chronic pyelonephritis. So we saw some pictures. We saw you get a big swollen kidney. How do you get chronic pyelonephritis? Recurrent acute pyelonephritis. So how do you get acute pyelonephritis? Well, bacteria. What I meant to say was, why would you get multiple episodes of acute pyelonephritis? And most commonly, it's due to vesicoureteral reflux, that typically congenital condition that we took a look at, in which urine goes from the bladder up into the ureters. If a kid's born with that and it's not corrected, then they're going to be getting upper UTIs for a long time, and they're going to get bad as the kidneys lose function and as the ureters and bladder continue to scar up with each sequential infection. And this patient is just never really going to stop being in acute danger of a UTI. So it get pretty bad. BPH, benign prostatic hyperplasia, is going to again obstruct the bladder, swell it up. You've got avoiding difficulty. You get some fluid backflow just due to simple hydrostatic pressure within the lumen of the bladder. And then recurrent stones, kidney stones, can get lodged in a ureter and predisposed to obstruction, but also infection. So if patients predisposed to stones, they're predisposed to UTI by default. Chronic pyelo is bad, can give you end-stage renal disease, as the continual scarring of the functional kidney eventually leads to a hypertension as fluid builds up, because you're compressing the outflow lumen. So fluid builds up in the tubules and eventually in the glomerulus. And so then you start getting glomeruli knocked off. And so the rest of your healthy glomeruli need to hypertrophy to maintain GFR. And that's not a good short-term solution, or long-term solution rather, because then they're just going to die too. Your podocytes will die, and then you'll go nephrotic after that. We're going to call it a non-obstructive or an obstructive pyelonephritis. We'll call it obstructive if you have a stone, or if you have BPH, or if you have a prostate cancer or a neurogenic bladder. So this is basically the adult version of chronic pyelonephritis. And then we can say that you've got non-obstructive pyelonephritis, which is going to be in kids, largely starting in kids. But again, these kids are going to grow up, and they'll be 20, 30, 40 years one day. So adults could have non-obstructive pyelonephritis too if they had vesicoureteral reflux that was never corrected. So understand vesicoureteral reflux. You're going to get a question about it. Reflux nephropathy likes to damage the poles. Again, that tends to be kids, but those kids grow up. And then obstructive pyelonephritis, the damage is from the bottom up, and once it hits the kidney, it's global. You've got a dilated ureter and obstructive pyelo. You've got a polar scarring and reflux pyelo. Histologically, what do you see? Dilated atrophic tubules filled with eosinophilic casts. They give a thyroid-like appearance. So that might get thrown to you on a test question. And you're also going to see thick-walled large arteries with tunica media hypertrophy. And then you're going to see glomerulosclerosis. starts from the outside and moves in. So how do we diagnose this? Intravenous urography is a good start. It's the best outpatient, I believe, procedure to schedule and go get done. CT is the procedure of choice, but really IV urography is going to show you these blunt and deformed calyces. And so even if you never order one of these in your life, understand that if they tell you that the patient's got blunt and deformed calyces on a IV gram of the kidneys, what that means is that they've got this chronic scarring process like you see here on page 14, and like we took a look at within my slides, big old scarred kidney. Here it is on the left. And let's look at chronic pyelo one more time on a microscope. You got those eosinophilic deposits. Nothing else in this SDL is going to give you anything close to that. So that is urinary tract infections. Thanks for sticking around. You keep killing the game, and remember, E. coli is #1 cause. Always, always, always E. coli, and just keep doing your micro for boards.